Hello, this is group 11, and we are doing our presentation on necrotizing fasciitis. What is known about the disease or infection? Necrotizing fasciitis actually means the flesh-eating disease. It is a rare, rapidly spreading bacterial infection and is most commonly seen at the extremities, perineum, and genitals. Immunocompromised people are at risk the most when it comes to this disease.
How does the infection start? There are 4 different types of necrotizing fasciitis. They are different because of the cause of the infection, not that there's an actual difference in the infection itself. So type 1 is polybacterial. This means that it is caused by more than one bacteria, and it can be a combination of aerobic and anaerobic bacteria. Type 2 is monobacterial. This means that it is caused just by one bacteria, and it can be either group A streptococcus or staphylococcus aureus. Type 3 is marine bacterial, and just like it sounds the name, it is caused by bacteria that is found in the sea, such as Aeromonas and Vibrio. Lastly, type 4 fungal, it's caused by fungi, and this usually happens, it's been seen only in immunocompromised patients. To keep it simple for today's lesson, we will be focusing on one of the most common types of necrotizing fasciitis that can happen to anybody, and that is Streptococcus pyogenes type 2. So type 2 monobacterial. So how does Streptococcus pyogenes cause the infection necrotizing fasciitis? So in order for the pathogen to get in your body, there must be some form of break in the skin, trauma, wound, even a small cut is enough for the pathogen to infiltrate your system. How does it evade the immune system? So there are M proteins and hydroloric acid capsule that protects the bacteria from being recognized. And just right here is just a picture of that, of the bacteria. And as you can see, this little hairline looking fuzziness around the bacteria, that's the M protein. And right here, it's kind of hard to see, but it looks sort of like a halo that's around the bacteria, and that's the hyaluronic acid capsule, protects it from being recognized and destroyed by the immune system. So what cells tissue is it in? So the cells that get affected by necrotizing fasciitis by the infection are macrophages and neutrophils, and this will be further described in the next slides. And it also involves the soft tissue. Soft tissue is the tissue that is under your skin, which involves muscles, nerves, fat, and even blood cells.
So what are the immune responses in the body? This bacteria can make toxins that can directly kill the tissue, as well as cause the immune system to destroy its own tissue while fighting off the infection. Massive release of pro-inflammatory cytokines is hypothesized to cause exhaustion in the patient and immune system, which causes them to be more susceptible to secondary infections. Researchers say that the absence of inflammation-inducing neutrophils at the infection site is the reason patients experience intense pain without the swelling, redness, and inflammation that develops when neutrophils are rushing to the wound. Th22 cells combat extracellular pathogens causing skin inflammation, while Th17 cells combat extracellular pathogens in barrier tissues.
In relation to the first cells in the immune system to encounter asparaginase, I'd like to first focus on the asparaginase, quote-unquote, invasion, which involves the entering of the dermis, leading to the triggering of an inflammatory neural response. This can then be followed by netosis, which is seen as a neutrophil activation of the net, which is identified as a paraffin-embedded tissue in response to bacterial infiltration. Furthermore, macrophages have been found to be a safe haven due to the fact that asparaginase has been found to reside in the phagocytic vacuoles, which allows for further bacterial replication within the whole cells. Furthermore, some of the signals that are sent to the rest of the immune system are further seen through the current pathogenesis that has been seen in literature related to asparaginase. This has been further depicted through bacterial toxin-mediated cytokine release by T lymphocytes. The signaling that is observed would be seen through the GAS, which stands for Group A streptococcal, and proteins, which are the superantigens that then come to bind to the MHC class 2 antigens on professional APCs. Furthermore, this leads to the binding to specific variable regions of the T cell receptor, which then induces cytokine release of TNF alpha, TNF beta, IL-1 beta, IL-6, IL-2, and INF gamma. And now looking at the effect that the immune response has on the microbe, this can be seen through the pain induction that is promoted by the exploitation of the immune system, which involves the activation of the nociceptor neurons and TRPV1+, which is a heat-sensitive ion channel, and the reduction of CGRP, which is a calcitonin gene-related peptide. Overall, as Aspergillus seeks to evade neutrophils due to the fact that they in turn, okay, and overall neutrophil evasion is found to be a microbial virus. And overall neutrophil evasion is found to be a microbial virulence mechanism for Aspergillus.
Symptoms of the disease. Early symptoms of necrotizing fasciitis include red, warm, swollen area of skin that spreads, fever, and severe pain beyond the red swollen area. The later symptoms are much more severe, with the formation of ulcers or black spots on the skin, color change in skin, pus, dizziness, fatigue, diarrhea, and/or nausea. Its name gives an idea of what exactly the bacteria does. Necrotizing means the death of tissues, while fasciitis means the inflammation of the fascia, or tissue under the skin that surrounds nerves, fat, muscles, and blood vessels.
And overall, in relation to the immune cell subsets that are involved in mounting the immune response against Aspergillus, CD15, CD3, and CD16A are some of the major markers that are noted in the literature. In relation to CD15, it is a distinguishing marker for human myeloid cells and mediates neutrophil adhesion to dendritic cells. CD13 is a receptor glycoprotein that is present on mature T lymphocytes and is found to be greater than 10% of inflammatory cells in skin and soft tissue. CD68, on the other hand, is highly expressed in macrophages and other mononuclear phagocytes and accounts for greater than 50% of inflammatory cells in skin and soft tissue.
So what other immune cells become involved? These would be cells displaying the CD1A positive surface marker. In necrotizing fasciitis' case, these can sometimes be expressed and account for less than 10% of the inflammatory cells present responding to the infection. The two cells expressing the CD1A plus surface marker are Langerhans cells, which are a unique population of tissue-resident macrophages that are effective class 2 MHC restricted antigen presenting cells. And when we take these and combine them with activated CD68 plus macrophages, they provide accessory activities for the local proliferation of immune T lymphocytes and cytokine release. The second displaying the surface marker would be dendritic cells, which we've learned are professional APCs great at activating T cells, and that is because of the large surface area that they have. The picture on the left also happens to show dendritic cells, which are the long black specks, and the blue stain cells are CD1A positive cells coming from a biopsy.
Does necrotizing fasciitis get resolved? Because necrotizing fasciitis is a really aggressive infection, the outcome can be either survival or death. According to the CDC, the mortality rate is between 24 to 34%. So 1 in 3 people will die from necrotizing fasciitis, and the mortality rate can be up to 60%. And that is because Aspergillus can cause both necrotizing fasciitis and streptococcal toxic shock syndrome, which a combination of both will give you a survival rate of like only 40%. So 6 out of 10 people will die from necrotizing fasciitis when streptococcal toxic shock syndrome is also involved.
Prevention of necrotizing fasciitis. There's currently no vaccine for this disease, but there are ways to reduce your risk in coming into contact with this bacteria. Washing cuts or open wounds with soap and water are good in preventing necrotizing fasciitis to infiltrating your body. Keeping the area of the wound clean and watching for signs that indicate spreading of infection are also good. The treatment for necrotizing fasciitis. So it's a rare bacterial infection and is able to spread throughout the body very quickly and can even cause death. So upon suspicion of having necrotizing fasciitis, prompt treatment is crucial. Antibiotics and surgery are usually the first two treatments for this disease. It's able to spread quickly, so surgery must be done much sooner than later if needed. The antibiotics used are injected into the patient's veins through an IV needle. These antibiotics used include linezolid, piperacillin, daptomycin, and clindamycin. Sometimes the bacteria kills enough tissue, it reduces blood flow and does not allow the antibiotics to reach certain parts of the infection. In this case, doctors will have to surgically remove the dead tissue so that the antibiotics can reach the site of infection.
Now that we've talked about the treatments, let's go ahead and look at the social impacts of developing this disease. Approximately 90% of patients report long-term pain between 7 to 98 months following hospitalization. There's also the development of severe scarring, more so than burn victims because it penetrates deeper dermal layers. Due to the deep scarring, people face distress with their appearance and reintegration into society following this disease. People also face restricted physical function. However, older patients had a more positive perception on their appearance, and individuals begin to feel this as well the longer that time passes since hospitalization. Here in the States, the prevalence of the disease is rare. Only about 700 to 1,200 cases happen annually. But let's go ahead and look at the global as well as the economic impact of the disease. Now, the median cost is $54,000 here in the States. This is due to the length of stay, the need for critical care units, and aggressive surgeries. That's very similar across developed countries equipped with the ability to treat the disease. For example, a study looking into the healthcare system of Australia found the median cost to be $64,000. So it's pretty close to home here. It's important to note that this is the cost without outside rehabilitation services that are often needed to regain the function or deal with pain in some patients. And developing countries, however, face a greater threat from this disease because it's a bacterial, and developing countries often face issues like poor sanitation, limited to no access to antibiotics or healthcare, and at times famine, leading to a malnourished population incapable of fighting the disease.
What are the important open-ended questions that have yet to be investigated? New ways to treat this infection is being researched. One of the ways scientists have found to treat this infection is a BONTA. BONTA is a bacterial toxin that blocks neurons from releasing CGRP, which is a protein that is released around the brain. When too much is being released, it causes inflammation and pain. With more experiments being done, it is found that pore-forming toxin streptolysin S causes the release of CGRP. People that have been infected are treated with BONTA or CGRP receptor antagonist, which stops the lesions from forming. With this, it puts a stop to this bacteria from replicating and spreading. BONTA and CGRP receptor antagonists are under new development to become a treatment to patients that have this infection. And these are our references.